Let's discuss about mental state examination today, signs and symptoms of mental illnesses. Now, since you have done mental state examination in the third year, I'm not going to discuss in detail about the basics. Instead, let's discuss about the practical problems and any issues that we have when we try to elicit symptoms in our ward practice. So I would like you to ask questions and discuss your concerns. Now, when we examine symptoms of mental illnesses, this is the usual order of mental state examination, starting from appearance and ending at insight. Now, there's no kind of logic behind this sequence. This is based on consensus. So almost every major textbook in psychiatry follow this order. And when you are asked to do mental state examination for your patients in the ward, you are supposed to follow this order because that's how we communicate. Then everyone follows the same order, then it's easier for us to communicate. That's the logic behind this. So you are expected not to mix up the order. You are not expected to elicit perception and cognition before speech and behavior. You're supposed to follow this order, right? Let's go into specific disorders and try to identify specific features of mental state examination in regards to those disorders. Now, I have taken some common examples. I have taken basically 3: mania, depression, and psychosis. Those are the basic things that we come across in the ward. In addition, we find patients with anxiety disorders, obsessive compulsive disorder, and other disorders in other settings, like in other wards and in our clinic settings. So if we start with the patient with manic symptoms, in your textbook under appearance, you might have seen that they dress in very bright colors and they wear jewelry, and when you look at them, they look quite extravagant, that sort of things. Now, you have to be careful in our setting with this description. Now, some of them might dress in colorful clothes, and it might give us an idea about their manic cognitions. But most of the times, our patients in our settings come to ward without much personal belongings, and the ward staff has to give them clothes and stuff. So for a depressive patient, they might give some bright clothes, and for a manic patient, they might give whatever is available in the ward. So even though it's mentioned in the textbook, you might confuse yourself sometimes if you follow the textbook to the word, right? And jewelry also. Now, some people, they anyway wear jewelry. Some people do not wear jewelry at all. Some people, now it's personal choice. So we have to know what their baseline is. Before becoming manic, were they wearing the same kind of, were they doing the same thing? Or did this change in appearance, is it something new in regards to the manic episode? That thing we have to be careful about. And in the behavior, you will expect them to have a lot of energy, manic patients, especially young patients. They have a lot of energy, so they will be quite, there will be a lot of movements, might find it difficult to stay in one place, might find it difficult to sit and have a long conversation with you. This again might not be the case in older patients. In old age, they are quite frail and they may not show that level of high energy even when they become manic in old age. So you have to be mindful about that as well. And people are usually overfamiliar. They might touch you, they might address you inappropriately, make sexual advances, talk about very intimate things, even though they saw you for the first time, could be disinhibited. And in speech, they will speak fast about a lot of things, and there will be flight of ideas. Do you have any idea about flight of ideas? What do we mean by flight of ideas? How do we identify flight of ideas? Those are the things that I plan to discuss. Anyone?
So when we are having conversation with them, they can't keep in the same topic. They frequently change the topics.
Yeah. How do you differentiate flight of ideas from thought disorder in psychosis? I hope you have heard of thought disorder, like loosening of associations. Let's say, how do you differentiate flight of ideas from loosening of associations? These people with loosening of association, which is a thought disorder, might change the topic as well.
In flight of ideas, there is no clear association between the different ideas, but in flight of ideas, there are clear association between the different ideas, but in loss of associations, there is no relevance in between.
Yeah. So how do you identify that? Sometimes a rule of thumb would be, now when people have flight of ideas, they will start from one place and slip onto another topic, and the topics will keep on changing, but still you are able to follow it. There is some connection between the topics, right? When you listen to the patient, you feel that you still can follow their speech. They start at one place, end somewhere else, but you can comprehend what they say. In loosening of associations, on the contrary, you find it difficult to understand or comprehend what they're talking about. They start at one place on one topic, and then move on to another topic. There is no apparent connection between these two, right? And third topic is entirely something that could be something entirely different. And since there is no connection, now we are used to follow conversations through connections, right? When there is no connection, we are unable to understand or comprehend, right? And if we ask them to explain or elaborate on what they said, the more they try to explain themselves, the more we find difficult to understand them when there is thought disorder, right? In overfamiliarity, we don't have that problem of understanding them. That is one rule of thumb that you can use in differentiating between flight of ideas and thought disorder, loosening of associations, right? In the mood, now mood is, by the definition, it's the prevailing state of emotions. That means it's not something cross-sectional. It is something that we see over a period of time. So with the mental state examination, during that short conversation you have with the patient, you may not be able, you only see a cross-section. Without a bit of history and background information, you may not be able to elicit the mood correctly, right? That cross-section in some textbooks is mentioned as affect. So there is a slight difference between mood and affect. Affect is the cross-sectional thing. Mood is the state of emotions over time, or maybe over a couple of weeks, over a period of time, right? We may need a little bit of history as well to claim that mood is elated or depressed or irritable, right? And in mania, some patients might have an elated mood. They will be excessively happy and joyful. And a group of patients may not show that elation, that happiness or joy. Instead, they might show irritability. So manic patients there can be two broad groups in regards to mood. One group could be elated. We call them happily manic. They laugh and they crack jokes and they have family and all. The other group is irritable, right? They could be aggressive. They could be hostile towards you. Okay. In thoughts, there could be other things as well, but one characteristic, main theme is grandiosity. That is, they think beyond their means. Right? How do you elicit grandiosity? How do you identify if a patient is grandiose? Now, without asking any question, the patient in their description, now when they are manic, they usually talk without stopping. It's quite difficult to stop them. In that speech, in that conversation, they might come up with extravagant ideas, the plans they have about the future and all. If they didn't come up with anything like that, you may ask them, what are you going to do now? The usual question I ask is, I don't expect you to ask the same question, but something that I usually ask is what they plan to do once they go home or once they're discharged. The grandiose patient will have very extravagant, big plans about the future. And sometimes you might not be able to differentiate whether this is grandiosity or whether they are usual, normal plans for the patient, right? This grandiosity could be a grandiose delusion, or it could be a grandiose idea. How do you differentiate an idea from a delusion? How do you know whether it is a grandiose idea or a grandiose delusion? Because usually students automatically say grandiose delusions. Whenever there is grandiosity, they say it's grandiose delusions, but it may not be grandiose delusions, could be a grandiose idea. Even other things, say, let's say a patient may have persecutory delusions or persecutory ideas. That there is a difference between these. Having a persecutory idea or a grandiose idea may not warrant a diagnosis of mania or psychosis. If they are deluded only, we can say that they are psychotic. So it's important to identify whether something is a delusion or an idea. How do you do that?
Delusion is a strongly belief that we can't change.
So that's the definition. How do you elicit that in a ward setting when you are with a patient?
So delusions are out of the range of patients' culture and beliefs and education levels. Ideas are within.
Tell me the things that you use to identify whether something is a delusion or a perception. What do you tell the patient, or what do you ask the patient?
So we can ask whether the patient is having any superpower to do something.
Okay. If they say they have, how do you know whether it's a grandiose idea or a grandiose delusion?
So I thought the grandiose ideas means even the patient doesn't have any job or something to earn. The patient thinks he can buy something very expensive.
That is the other
one? Delusion. I thought the delusion means the patient, if the patient tell, I can create food for others.
Anything more specific than that? Let's say the patient says that I have a lot of money, or let's say the patient says that somebody is there after them trying to kill them. How do you know whether this is a delusion or an idea? If it's an idea, we can't say that the patient is psychotic.
In a grandiose idea, patient has a clear plan about what he's going to do, and in a delusion, it's out of the reality.
Yeah. Now, how do you identify that? What do you do to establish if something is a delusion? What can you do with the patient?
We can ask about patient's experiences regarding that past or anything happen.
Okay, now by definition, a delusion is a firmly held belief. What are the other words? Firmly held belief, which is?
To check whether it is an idea or a delusion, we can
I can't hear you properly.
If it changes, differentiate an idea from a delusion.
Yeah. I can't hear you properly. You're breaking up.
The idea that.
All right. So a delusion is firmly held, and an idea is not so firmly held. So now, if a patient says that there is someone out there to kill them, you can argue with them, or you can confront them about that thought to see if it is firmly held. Now, if you can argue with them or convince them that there's nobody out there, and if patients agrees with you at least for a short period of time that it may be just a thought, that if he doesn't firmly believe in that, then it is not a delusion. In a delusion, you can't argue with the patient. You cannot convince the patient, and the patient is not going to look at any alternative possibilities. He's firmly now holding on to his idea. Right? He will say that there is someone out there after me trying to kill me, and you can't shake that idea whatsoever. That's how you differentiate whether something is a delusion or not. Right? So you have to establish if something is grandiosity. Now, for grandiose delusions, you have to establish both parts of that term, grandiosity and delusion. So theme should be grandiose, and that thought should be firmly held, unshakable. Right? You can try to change the idea with the patient. Right? And if you can't do that, if the patient is firmly holding on to that, then it's a delusion. Those are the things that you need to do with the patient when eliciting psychopathology. Right? In perception, there is nothing characteristic about mania. They can have auditory hallucinations. Visual hallucinations are very rare. Right? Now, usually, I have seen medical students giving equal weight for auditory hallucinations and visual hallucinations. They say sometimes that the patient has auditory and visual hallucinations, right? Or sometimes they say the patient has auditory hallucinations. So you have to be really careful about visual hallucinations, because they are quite rare in the first place. And in the second place, they point towards something specific. If they really have visual hallucinations, what do you think of? What is the alarm that is ringing that should ring in your head when a patient says that they have visual hallucination, or when you think that a patient is having visual hallucinations? What does it point towards? Visual hallucinations.
So visual hallucinations mainly point towards an organic cause.
Yeah. So you have
then.
Yeah. So visual hallucinations usually point towards an organic etiology, or something organic, whether something organic is going on inside the head. Right? So it's not very common for manic patients, or even for schizophrenic patients. Visual hallucinations are not quite common. How do you ask the patient whether some patients, when you observe them in their appearance and behavior, they might respond to their internal stimuli. They might respond to their hallucinations. Right? If they have auditory hallucinations, they might look about and they suddenly become startled. Then we can assume that they might be hearing things, or even they might be seeing things. Right? If that didn't happen when you observe them, if you didn't notice that them responding to hallucinations, how do you elicit hallucinations? What questions can you ask? How do you ask for hallucination?
You can ask whether he hear any noises or whether any commands given to him?
If they say yes, how do you know whether it's hallucination? If you ask whether they hear noises, how does the patient know whether you're asking about normal noises or whether you're asking about hallucination?
So you can ask, when you were with a group of people, did you hear things that other people didn't hear?
Yeah, you have to make that differentiation. You have to ask whether that person is experiencing things, perception that other people do not. So if you are looking for auditory hallucinations, you should ask whether they hear things that other people around them do not hear. Usually the family members tell them that we don't hear anything like that. It's all in your head or something like that. So always you have to make that distinction between them and other people. Do you see things that other people do not see when they are around you? Don't just ask whether you hear voices, whether you see things. Saddhayanada, rupapenada. And when the patient say yes, don't just jump into the conclusion that they have hallucination, because you will miss the diagnosis in that case. Right? Any questions regarding those?
So, meant by disinhibition?
Disinhibition means that now in social context, we don't express everything that is in our minds, right? The sexual things, what we feel about other people, what we think about other people, we don't express them. We just keep them to ourselves. We inhibit them, right? Using our frontal lobes. Disinhibition means they come up, they verbalize everything that's going on inside their minds, usually the sexual stuff and what they think about other people and all. So that's called disinhibition. They can't hold back. Whatever comes to their mind, they will express.
Flight of ideas and thought blocks, like things are mainly we say it under thought, like thought process. Then still we assess them in under the speech, or
That's the thing. Now the flight of ideas are, in fact, they are thought content, right? But we elicit them in speech. So that's why you mention them under speech. In fact, it is the thought content. It doesn't matter even if you mention them under thought content. Anything else?
So what is meant by a subjective and an objective mode assessment?
That is subjective mood is that now some textbooks and some schools of thought mention this thing about objective mood and subjective mood. Objective mood is what we elicit as examiners or doctors. That is, which is what we elicit said to be objective. Subjective is what the patient feels, what is the reported mood, in other words. Right? But some authors or some schools of thought claim that mental state examination is that is something the doctor does, right? So it's your interpretation of things. So the subjective thing doesn't matter much. What is reported by the patient, you can mention in the history. So there are those two arguments are there. Subjective mood is what is described by the patient. Objective is what you elicit. Right? I usually don't go to that distinction. What I mean by mood is what I elicit as a doctor. So if somebody asks you in the exams, you should know the difference between them, but it won't be a problem. Any other questions? Now, under cognition, you usually look for consciousness, level of consciousness, attention and concentration, memory. Usually in many patients, there will be a problem with attention and concentration. They have racing thoughts inside their minds. So they might find it difficult to pay attention. So the attention span will be quite low. And insight is whether the patient knows that they have this problem. Why do we need to identify whether the patient is insightful about their problem? Is that it helps us in the management. If the patient thinks they don't have any illness, then it will be really difficult for us to treat them. If they don't think they have an illness, they won't be willing to take treatment. So if we have an idea about the level of insight, we might be able to make management decisions, whether to admit the patient or whether to send the patient home, whether we need someone to supervise medications, whether we will have to give them oral medications. So if we have depot options, to go for them. So that's the importance of getting an idea about the insight. If you have any further questions, you can ask me later. Otherwise, we'll run out of time. Any other questions? Shall I move on to this one? Now, in depression, you have to keep in mind the same things that I said about the appearance. There's this special thing about facial appearance in depression. You will see, you might have seen that description in the book. Drooling shoulder, the drooping shoulders, and this horizontal furrows on the forehead, bent neck. They don't make much eye contact and such things. And level of energy will be low. We call it psychomotor retardation when it is quite severe. Patient make very little movements, right? Don't make eye contact, look sad, and all of that. And in speech, latency is when you ask a question, the answer might not come instantaneously. They will spend some time. They will spend quite a lot of time before answering the question. So you might sometimes think that the patient is not going to answer your question. You ask a question and then you wait for a few seconds, and then you might want to move on to the next question. You might ask the next question, and then the patient might answer the first question. That's called latency. They take time, probably because the processing is slow and there is psychomotor retardation. So in depressive patients, keep in mind that if the answer doesn't come, you might need to stay for a while to see if there is latency in speech before deciding that the patient doesn't answer your questions or anything. And positive speech is, there could be a very little speech when in contrast to a manic patient. Right? They may give very short answers after quite a latency. And you might have to ask a lot of questions to get information, to gather information about the illness. Mood will be low, they will be feeling low, and mood will be depressed. There will be pessimistic thoughts in contrast to the grandiose thoughts that you see in mania. One main theme in depression would be pessimism. They see things very negatively about the future, about themselves, about their relationship with others, will be quite pessimistic. Right? This could go into a delusional level, and one characteristic delusion is called nihilistic delusions, that they think that their body organs are not functioning, bowels are rotten, and there is a foul smell coming from their mouths, and even some people say that I am dead. That's called, they cease to exist. Nihilistic means nothing is happening, they cease to exist. So the pessimism could go to that extent when they are deluded. Then the diagnosis would be depression with psychotic symptoms. Perception also, they will hear voices about very negative things, people making derogatory comments about them, about the patients, and so on. And in cognition, the depressive patient will have problems with attention and concentration, right? Not because of racing thoughts, because they worry about things, and they might find it difficult to pay attention to something else, right? And usually, unless they are deluded, they usually retain the insight. They usually know that they are depressed and feeling low, and unless they're deluded. Do you have any questions about that? You need to raise questions about the mental state examination. Now, in the exams, you might be, now on the other day, we discussed about how to do assessments. And I told you that you don't have to follow mental state examination from top to bottom after history, and then you don't go to mental state examination. We discussed something else, how to incorporate components from mental state examination and history and physical examination in that logical sequence that we considered in taking differential diagnosis. But if you are asked to do mental state examination from top to bottom, from beginning to end, in this order, you should be able to do that, to show that you know it. Right? You're not expected to do this in a normal patient encounter. You're not supposed to do this from top to bottom for every patient. In clinical encounters, you are supposed to do that, what I told you the other day. But in exam settings, in assessments, you might be asked to conduct a mental state examination, right? Then you have to do the sequence to show your knowledge. Any questions on this?
So there is a question.
Yeah.
There is then the same thing. If you think about the perception thought disorders, if there is a patient with any psychotic symptoms, the same thing we are going to explain in the history as well. That means if the patient complains of hearing sounds, then we explain the whether he has a true auditory hallucinations in the history as well. And we are repeating the same thing in the mental state examination as well. So is there is a
no, you don't mention the technical terms in the history usually. Now, the broad distinction is the history is the patient's version of the things. Physical examination and mental state examination is your version of things. It's your interpretation. History, we don't interpret, that we just record. But the just record means that is the patient's version. Now, if the patient says that they hear voices, let's say the patient hears, they say they hear voices of two people commenting about themselves, and you just mention that in the history. The patient hears voices of two people commenting about themselves. That's it. On the mental state examination, you can say that they have auditory hallucinations, third person auditory hallucinations, which is he hears two people commenting about themselves. So you don't use the technical terms in the history usually. That interpretation is only done in the mental state examination. So there is no repetition of things in history and mental state examination, right?
Thanks.
Any other questions? Oh,
yeah. So what is meant by delusion of perception or perceptual delusion?
I'll discuss about that in the next section, eliciting psychosis, delusional perception, right? Yeah. So in psychotic patients, there's nothing much significant about appearance. In their behavior, they could be responding to internal stimuli, hallucinations. This may not be the case. Sometimes they might just look normal, just like you and I, if we are considered as normal. In speech, some of them may have thought disorder. Thought disorder is that now in our thoughts, we have a connection between thoughts. Right? That's why we are able to, that's why I am able to speak on this topic for half an hour or 1 hour. Now I can speak on mental state examination for half an hour or 1 hour because I can maintain a connection between my thoughts. So there is a connection between my sentences. My first sentence is related to my second sentence. There is a flow that the listener could follow. In thought disorder, what happens is this association between thoughts, between one thought and the other thought is broken. In early stages of thought disorder, this association between thoughts could be loosened. Right? We call it loosening of association. How do we elicit that clinically is when a patient talks to us, when we have a conversation with the patient, when he moves from one topic to the other, we might find it difficult to understand what the patient says. It's nothing to do with the language. It's nothing to do with the phonation. But still, we find it difficult to understand what he's talking about. Because there's a loosening of association. There's a loss of connection between thoughts. When it is severe, this loosening of association, loss of contact between thoughts could be so severe that there is no association whatsoever between thoughts. That's very severe psychosis, very severe thought disorder, and there's a word for that. We call word salad. It's when the person speaks, we are unable to understand anything at all. We just hear a group of the salad of words, right? Word salad. It's just words, one after the other, and there's no connection whatsoever. And because this is something inherent going on inside their minds, when we don't understand, we usually ask them to explain. We try to understand, and the more they try to explain themselves, more confused we become, because the thought disorder is taking place in their minds, and they can't make sensible sentences. They can't construct sensible sentences or maintain a topic. Right? That's the thought disorder. You usually don't see patients with word salad these days, because before they go into that stage, we usually identify them early in their psychosis and we treat them with antipsychotics. So we don't have such severe patients. So you don't have to worry about word salad and things in clinical settings unless they ask you about such things in the MCQs. But loosening of association, yes, you might see patients displaying loosening of association. That is slight, mild degree of thought disorder. The mood, there could be an incongruity in the mood. Incongruity means there is no connection between the mood and thoughts. Now, usually we have our mood and our thoughts go hand in hand. If we talk about sad things, we look sad, right? We might cry. The depressed patient might talk about very pessimistic things, and they might cry, or they might become tearful, or you might see them. You might see that mood is low. In a manic patient, they could be grandiose, and in the mood, they will be elated. They laugh and they crack jokes and all. Incongruity is thoughts and mood do not match. They might talk about something very sad, people, somebody dying, some loved one dying and things like that. And at the same time, they might laugh. So the mood is, mood could be elated and the thought content could be very pessimistic. That is called the incongruity of mood, mood incongruence. That could be a feature of psychosis, specifically in schizophrenia. Hallucinations, they could have persecutory delusions, second person auditory hallucinations, could be third person auditory hallucinations. In delusions, they might have persecutory delusions. Insight in psychosis is almost always poor. They usually don't realize that they have a problem, and they usually are not willing to take treatment. That's why we usually have to admit these patients in the ward, unless otherwise they won't be compliant with the treatment because of lack of insight. Delusional perception is, I'll move on to the next slide. Now, schizophrenia is a special kind of psychosis. You will you must have heard of this first rank symptoms of schizophrenia. Delusional perception is one of them. Delusional perception is you have a normal perception. You see something that's not a hallucination, but still you interpret that perception in a very delusional way. A common example given in the book is that the patient is driving and he stops at the color light and the light goes red, and that he interprets as a warning or an indication that his wife is going to die. The light turned red, therefore my wife is going to die. And there's no connection between the perception, light going red and wife dying. There's no connection whatsoever between the perception and the thought. That's called a delusional perception. And he's so convinced about the thought, that's why we call it a delusion, that he knows that his wife is going to die because the light turned red. That's called delusional perception. That is a dissociation between the perception and thoughts. And in schizophrenia, now you must have read these things. Thought insertion is there, thought withdrawal, broadcasting, passivity, thought echo. These things are called and some, including some other things as well. These are called first rank symptoms of schizophrenia, introduced by Schneider. Schneider's first rank symptoms of schizophrenia. These were diagnostic criteria used before ICD and DSM. And now these things, the first rank symptoms of schizophrenia, are incorporated into ICD diagnostic criteria, and you see these things in ICD, diagnostic criteria of schizophrenia. Now, one common, what is common about these things is thought insertion, withdrawal, broadcasting, passivity, thought echo, and these things have something in common. That is, we have a sense of identity about our uniqueness. We have a boundary for our, a perceived boundary for our thoughts. We know that our thoughts are private to us, right? Other people cannot get to know about our thoughts. We have no access to other people's thoughts. We are separate individuals. We have separate egos. We have ego boundaries, right? My ego has a boundary. The other person's psyche has a boundary. So there is no trespassing between these boundaries. I have no access to other person's thoughts and they don't have access to my thoughts. What happens? One core thing, one core symptom of schizophrenia, almost diagnostic of schizophrenia, is there's this blurring of ego boundaries. My boundaries are blurred. Right? My thoughts are not private to myself anymore. They're going out of my mind. They are broadcasted and other people can get to know them. Right? And other people's thoughts are inserted into my mind, right, through the boundary. My thoughts are taken out from my head. Usually we know that we are a unique agency. If I want to move my hand, I do that. Right? If I want to speak, I speak. And I think. Nobody else is influencing my movements or my emotions or thoughts. Passivity is, this boundary is gone. My hand, the patient might think that their movements are controlled by outside agencies. My hands are moved by other people. Some patients say that mage katin katha karana. This is not I am speaking. Somebody else is speaking. Somebody else is making me speak. I don't want to do this. This is not me. This is somebody else speaking through me. That is passivity. Or they might say that they make me feel sad. I don't want to feel sad. They make me feel sad. That is passivity. And thought echo also, the thoughts are inside our minds. Thought echo is you hear your own thoughts. So it's gone out through the boundary. So the common thing about these things is it's the blurring of ego boundaries. Now I have taken this picture. This is taken from the older edition of Sims' textbook of psychopathology. Sims, you have this book in your medical library, Symptoms of the Mind. This drawing shows some form of losing boundaries. Now, their limbs, the patient limbs are continuing onto the floorboards. The person is blended into his environment. So this could be an expression of this blurring of boundaries. So schizophrenia in this sense is a special kind of psychotic illness when you have this kind of symptoms. Any questions on this?
In these symptoms, thought insertion, withdrawal, and broadcasting, we consider it as a delusional thought disorder, and but we consider thought echo as a hallucination.
Yeah, thought echo is a hallucination because you hear your own thoughts. You know it's your own thoughts, but you hear them in your ears. That's why. In other things, there's no perception. Thought insertion, it's a belief. Thought insertion or withdrawal or broadcasting is a belief. They believe that their thoughts are gone or inserted. In thought echo, there is a perception.